Help me. Resuscitating the unresponsive ventricular assist device patient with Darth VAD.R. Episode 4, A New Algorithm. VAD patients are complicated and may strike terror in the unprepared emergency physician, but they're not too complicated, and in this episode we will address resuscitating the unresponsive VAD patient, common VAD complications, and basic VAD components of the HeartMate 2 and Heartware systems. As our intern demonstrates, the first step is to get backup.
Looks like we're getting a VAD patient. Hey, R2, we're getting a VAD patient. Me and that S-Fast have been through a lot together. You're still a pretty piece of junk, though.
VAD.R arrived. Open the trauma airlock.
Assuming the airway has been secured, let's go through the first steps of evaluating this patient. Step 1, check for a pulse. Step 2, listen for a hum.
Hey, guys, can you keep it down? Try and listen for a hum here.
Step 3, measure a map. Your goal is to remain between 70 to 80 millimeters of mercury. This is also a good time to get a call out to the patient's VAD coordinator. So now, let's see how these steps fit together into an algorithm and get into some VAD-related complications. After securing the airway, check for a pulse. Other people recommend listening for the device first, but this is a better starting point. This may be counterintuitive since VAD patients usually shouldn't have a pulse, but they may have one from either increased heart function or residual function after their VAD has failed. Whatever the case, it is a simple thing to do, and if they have a pulse, you don't have to worry about coding them just yet. Your next question should be, do I have a decent mean arterial pressure? If you do, then you can go down your altered mental status pathway. If you don't, then address the hypotension with some VAD-specific things that we'll talk about shortly. Most likely, though, you're not going to have a pulse, so the question becomes whether they have a hum, which means the device is working. The hum actually sounds like this. If they have a hum, then we're back at the hypotension versus altered mental status branch point. Here, we'll just highlight some key points of the hypotension workup, and this is really where your bedside ultrasound may help out. To begin with, are they hypovolemic? These patients are susceptible to GI bleeds, hemolysis, and dehydration. A good old ED handshake is probably in order. Next, are they septic? VAD patients are susceptible to driveline-related skin and soft tissue infections, bacteremia, and candidemia. Then, do they have evidence of tamponade? A quick look at the pericardium can tell you this. Suction events can also happen when part of the myocardium is sucked into the inflow cannula due to dehydration, malposition, or inappropriately high VAD speeds. Usually, VAD power will go up while speed will go down. A fluid bolus and decreasing the speed may resolve this issue. Finally, let's talk about some VAD-specific cardiogenic issues. First, VAD patients can tolerate otherwise fatal arrhythmias with minimal or no symptoms. This patient in VFib presented only feeling mildly dizzy, while this patient stayed in total asystole for over 3 months. Unstable patients in ventricular rhythm should be shocked to return them to a native rhythm as soon as possible. You may also have a VAD thrombosis on your hands. The 3 places where a clot can form are the inflow cannula, the pump itself, or the post-pump sheath. Thrombus within the pump usually leads to an increase in pump power usage with a maintained calculated output or flow rate. The VAD may be warm and you may see gross hematuria on exam. Thrombose pumps usually need to be replaced. Pre- and post-pump thromboses present with similar pump findings of low power and low flow. Pre-pump thromboses typically cause changes over hours, while post-pump thromboses manifest over days. A contrast-enhanced CT may help identify where the clot is. In this case, we can see a clot in the VAD's outflow graft as a large filling defect. A table of normal VAD parameters is provided in the accompanying web post. Consider starting a heparin drip when thrombosis is suspected. Pre-pump thrombosis may be amenable to thrombolysis, while post-pump thromboses may be stented. It's a little difficult to read, But here our initial settings are a power of 3.4 watts and an output of 7 liters. When we simulate a pre-pump thrombosis, both our power and output go down and soon trigger a low flow alarm. Last, we'll just mention that these patients can have right heart failure or aortic regurgitation causing a loop between the VAD and the native heart, but none of these really change your ED management. But wait. You may be asking, what if I don't have a pulse or a hum? At this point, you're going to have to become a VAD mechanic. We'll discuss these issues using the HeartMate 2 as a demonstration. First, check the power. Each HeartMate 2 should have 2 batteries that connect into an adapter by lining up the arrows, as our VAD coordinator shows. The adapter attaches to the VAD's power cable by lining up the semicircles. If your batteries are dead, there may be a wall module that can supply power as well. Next, check the drive line, which is the cable that supplies power to the VAD motor. Make sure the connector pin is securely in place. The switch on the back of the control box will not close unless the connector is correctly inserted. Also, in the unlikely event that your drive wire has been transected, you can MacGyver it back together, connecting the colored wires with clamps and electrical tape. Third, the VAD control box may be malfunctioning and need to be replaced. Usually an alarm instructing you to do this will be flashing. VAD patients should carry a backup control box on them at all times. We'll demonstrate how to change the control box using the hardware system. Let's begin with an overview of the hardware components, which are similar to the HeartMate components. The hardware's driveline attaches to the control box, but without the special lock that the HeartMate had. The control box has the same display we saw earlier. Finally, the hardware has 2 batteries. Unlike the HeartMate, the batteries and their cables are one unit and only detached from the control box. The steps to changing the control box should be followed in order. Make sure you have all your equipment lined up and ready. The patient's VAD will temporarily shut off when you switch control boxes, so you want to do this as quickly as possible. First, connect the new control box to one of the batteries. Second, you can change the silencer over to the other controller. Third, transfer the drive wire, aligning the red dots. Fourth, attach the second battery to the new controller. Finally, if you've done all this and still have no pulse, hum, or pressure, you're going to have to code them. Unless you want to think about ECMO cannulation. While there's no evidence that chest compressions lead to VAD dehiscence, it's probably best to follow your institution's protocols if you have them in place. If you are a no compression center, you'll have to proceed with a chemical code. To recap, we've identified the 3 key questions to ask when faced with a VAD patient: pulse, hum, and blood pressure. We've gone through how to deal with VAD-related complications, as well as how to troubleshoot the VAD itself, and how to code these patients. Now it is time for you to take this information back to your planets and boldly go where no emergency physician has gone before.